Can I start? Okay. Okay. So we're gonna have a pro-con debate today about ECMO. So I don't have any disclosures. I'll be doing the pros and Khalid will be doing the cons. So why are we having this debate? That's I think this is a non-FDA approved therapy for ARDS, so that's why I just have to put that out there when I start. But ECMO, especially VV ECMO, is used in severe ARDS. This was recently published in JAMA actually last month, and it discussed the epidemiology, the patterns of care, mortality in ARDS, and among the ICUs in 50 countries, the period prevalence of ARDS was 10%, and of those 10%, the severe ARDS ones were 23%, and in different literature, studies have shown that the mortality associated with severe ARDS is as high as 52%. So why are we discussing ECMO? Like I said, it's not an FDA-approved therapy for ARDS or severe ARDS, but this is from the Extracorporeal Life Society, the organization that actually keeps a tab of all of the ECMO centers in the world. If you see from 1990 to 2015, the number of ECMO centers in the world and the cases being treated with ECMO, regardless VV, VA, ECOR, or in peds or adult, has gone up significantly. So since everybody is doing it and this is the hot topic, that's why we're discussing it now. So before I start, I wanted to have this quote. Galen was actually a physician surgeon in the Roman era, and he had this quote about whenever he was treating somebody, he would say of the cure that he had, all who drink of this remedy recover in a short time, except those whom it does not help, who all die. Therefore, it is obvious that it fails only in incurable cases. So he was pretty confident in whatever he did. I just feel like when we are treating patients at times, and when our treatments are failing, we just behave like Galen, like, oh, they must be dying then. If we can't ventilate them, we can't oxygenate them, then, well, they're too sick to live then. So that's, I think, where the debate of ECMO starts, that where should we start questioning or bringing up the idea of ECMO. I'm going to start off, this is the overview of my talk. I'm going to start with a case presentation, some basics and background of ECMO. I think we've already had a lecture on basics of ECMO, so it'll be really short. And the data on ECMO, when I was reviewing this, ECMO's been there for a while, but if you basically divide the literature, it's basically before the H1N1 pandemic, and then after that is when ECMO really became popular with physicians. When I say ECMO in this presentation, it's going to mean VV ECMO, because we don't really have a role any other modes of ECMO like VA in ARDS. I'll mention the one trial that actually did the ECOR, which is extracorporeal CO2 removal. But then if I say ECMO, it's going to mean VV ECMO. So, and then the current role of VV ECMO in ARDS, the challenges and expectations. And then lastly, I'm going to touch on the lack of appealing alternatives we have when all else fails, and refer to an ECMO center. So the case presentation. So I had this patient actually last month, beginning of my month. It was a 45-year-old woman with pretty healthy, just had hypertension, newly diagnosed diabetes, came to the hospital with just malaise, flu-like symptoms. She, in that outside hospital, deteriorated pretty quickly and was intubated. I got a phone call about her carrying the triage phone that they couldn't oxygenate her. She was heading in the 50s, and they just wanted a referral to for escalation of care. So this is her actual chest X-ray. That's actually not her. This is somebody from Google. So just so you guys know. So she came in, she had these bilateral infiltrates, she was flu positive, and intubated. We paralyzed her overnight. That did improve her oxygenation a little bit. And the next morning, she was again difficult to oxygenate, so we proned her. We kept her prone for 5-6 hours, but then the issue started becoming of ventilating her, and then her PCO2 went up as high as 118. Her pH dropped to 7. We kept increasing the respiratory rate, but she couldn't ventilate at all. So that's when we brought up the question of ECMO, and we actually called the cardiothoracic surgeon, was nice enough to come in at 9 p.m. and put in ECMO catheters. This is Day. I don't know if somebody's here from Team Blue Red, but she's been on ECMO for 22 days now. Going back, so basic concepts of ECMO. So ECMO's been there for a while now, or at least the concept of ECMO. It dates back to 1939 with the development of the first heart and lung machine by John Gibbon. ECMO is basically, like I said, a generic term used to describe different techniques used for prolonged artificial cardiac and or respiratory support. VA is veno-arterial, which when you support the heart as well. VV is just bypassing the lungs. So VV ECMO diverts a fraction of the patient's blood flow through an artificial lung for gas exchange. Again, available only in referral centers with expertise in the management. It is frequently used in the neonatal ICU for neonatal respiratory distress syndrome. Thank you. So the terminology, like I said, extracorporeal life support, ECMO, VV, VA, ECPR, again, I won't touch on any of those, and then extracorporeal CO2 removal, which is pronounced as ECOR. So the only thing that I'm going to discuss is VV in ARDS. Basic concept, starting from, will this work? Like the pointer would work, right? Starting from the bottom here, there's basically a drainage cannula coming from the patient, goes in, there's a pre-pump pressure measure, and then there's a pump, and then the blood flow sensor after it goes out of the pump, and then the oxygenator, which is the artificial lung, takes the CO2 out, oxygen in, and then goes back into the venous side. This is red because they're just, I think, depicting that it's oxygenated, but it goes back into the venous end. These are the 4 basic big things that we look at when we're at the bedside: the flows, the pressures. But again, I think we've had a lecture on ECMO, so I won't really dwell much into it. Just how the setup of ECMO, it's basically in series with the patient's lung. So the oxygenation, this helps the PO2, but the patients on a VV ECMO, it's still dependent on the patient's cardiac output to help with the oxygen carrying capacity. So the first reported case of ECMO, interestingly, when I was going through, is actually in, I think, 1972. This is in NEJM. They reported this 24-year-old kid who got into a car accident, had a shock lung at that time, and they put him on a VA ECMO, and he survived through this. So this was the first reported case of a successful ECMO patient. Since ARDS has always been associated with high mortality, there was then an idea that what if this VA ECMO would help us in managing ARDS. So this was an NIH-sponsored trial. At that time, this was in 1979, and this was a prospective, randomized prospective study. This is one of the 3 randomized control trials which we just have 3 randomized control trials on ECMO. That's all we have. So there's not a lot of literature, but there's this a variety of, like, a lot of case reports and case series that came out after the H1N1 pandemic. So you're going to hear us talk about all these 3 randomized control trials. This was the first one, the NIH-sponsored one, and it was a multi-center trial in 9 centers. It went on for 2 years. They had 90 patients randomized. The entry criteria, there were 2 entry criteria. There was a fast entry criteria and a slow entry criteria. So the fast one was if the PaO2 in 2 hours of patients intubated severe ARDS, in 2 hours after giving an FiO2 of 100%, if the PO2 the PF ratio is still less than 100, then they refer them with a PEEP of greater than 5. Then he gets enrolled. The slow entry criteria was 48 hours of medical therapy, then a PaO2 less than 50 for more than 12 hours at an FiO2 greater than 60%, and a PEEP greater than 5. So the slow and the fast entry criteria, so they had 90 patients, again, multi-center randomized controlled trial. The exclusion was if they were less than 12 or more than 65 years of age. So 42 patients were actually randomized to a VA ECMO. So this is not the current practice anymore, but just to know what one of the 3 randomized control trials were. 42% were randomized to VA ECMO, and what they found was pretty impressive. They actually found that there was a 90 to 92% mortality in both the groups. So that basically showed that putting a patient on VA ECMO in severe ARDS didn't really make a difference at all. Actually, in the control group, it was 90% too. So the mortality was high in both the groups. The criticism of this, one of the things is we don't use VA ECMO anymore. So I don't know if this study can be quoted for pro or con. The other one is, if you have such a high mortality, how can you statistically say anything statistically significant, like one is worse, but it did show that it didn't actually help in patients with severe ARDS. While on the peds side, these actually studies came out in the 1980s, and they actually showed improvement, actually a mortality benefit with ECMO. So that's why on the peds side, ECMO is actually now the standard practice in neonatal respiratory distress syndrome. So this is the second randomized control trial of the 3 that we have right now. This came out in 1994. So Dr. Gattinoni is at U of M, and he actually didn't agree with the first trial that we needed a VA ECMO to treat a patient with ARDS. So he did a study at U of M, and he actually did lower flows. He had a VV ECMO circuit, like it went from the fem vein back to the fem vein, and he just put patients on a pressure control inverse ratio ventilation, and the issue that he had was CO2 retention, so he did just the CO2 removal with this. So it was just E-core. So again, not the practice that we did, but he actually showed some improvement. So Morris et al. Actually tried to replicate this as a randomized control trial. They actually had, so this is the trial in 1994, after Dr. Gattinoni proved that E-core can be used with pressure control inverse ratio in patients with severe ARDS. So again, this was a randomized control trial. They had 40 patients. They had 19 controls. 21 patients were attempted pressure control inverse ratio ventilation. If they succeeded in ventilating, oxygenating them and properly ventilating them, that's fine. But if they failed, then they would start E-core on them, which is extracorporeal CO2 removal. Interestingly, only one patient actually did really good on the pressure control inverse ratio and did not go on the E-core. At the end of the study, what they concluded was that it had no survival difference, it had no hospital day difference, no difference in the ICU stay of the patient, and basically it concluded, and I quote, "We failed to find a statistically significant difference in survival between control and extracorporeal treatment patient groups." So they couldn't really replicate what Dr. Gattinoni could at U of M. But after this, there was, in literature, there's a hold in things coming out for or articles trying to go for and against ECMO. U of M actually carried this on, though. They actually had these 2 articles that were published as a case series, because they continued to do ECMO. And the first one on the top actually was published in 2000, and this is basically a case series of 1,000 patients, and this is the largest case series of ECMO patients in one center. And they published this, and it had 146 adults in this study, and they counted all the peds and the VAs and the VVs. 146 were the VV ECMOs in ARDS, and they actually showed a 56% survival on an ECMO. Again, it was just a case series. And then again in 2004, the one in the bottom is again from U of M. This was from the Department of Surgery at U of M, that they had patients from some patients from the earlier case series. So they actually had patients from 1989 to 2003 with severe ARDS patients with PF ratio less than 100 despite maximal vent settings. And they found the same. They found around 52% survival with using VV ECMO in severe ARDS patients. So these are just case series from U of M. Now the post H1N1 pandemic in ECMO. So, yeah.
What was that compared to? 52%. What was their normal mortality?
So they didn't mention this. So this is just a case. They just reported their results on how the survival on the patients with ECMO. Okay. So the post H1N1 pandemic. So this again with the H1N1 patients having flu, difficult to oxygenate, ventilate. This study is actually on between July 2001 and August 2006. This was done in UK, and the inquiries were made about 766 eligible patients from 148 centers, of whom 180 patients were actually enrolled from 68 centers. And the 180 patients that were enrolled, of those actually 90 were sent to this one Glenfield hospital, which was a center of excellence for ECMO, and the rest were treated at their respective institutes. So 90% got transferred. Royal Air Force actually helped. They actually flew those patients to Glenfield Hospital if they were meeting the criteria and they were accepted. The other ones were left in their respective hospitals. Interestingly, so the inclusion criteria was age 18 to 65, severe ARDS with PF ratio less than 100%, or they could have hypercapnic acidosis with a pH less than 7.2. The lung injury score, or the Murray score, you guys all know the Murray score, right? Like it's the PF ratio, the chest X-ray changes, and all. It just accounts for how severe the ARDS is. The higher the score, the worse the outcomes. So lung injury score was greater than 3. Exclusion criteria was if they were actually on a vent for too long. So a peak pressures of 30 or an FiO2 of 80% or more being vented for more than 7 days. So they didn't take patients with high FiO2s and peak pressures being on the vent for more than 7 days. Again, since they had to be anticoagulated for ECMO, they wouldn't take people who had contraindications to anticoagulation either. Like I said, it was randomized to either usual care or transferred to Glenfield Hospital. So what they found was, outcomes-wise, they found that death and disability at 6 months, compared with the coming out from the ECMO center, compared to the other hospitals, so 37% mortality in the patients from the Glenfield Hospital, which was the referral center, versus a 53% mortality from all of the other hospitals. Interestingly, there is actually a caveat to that. So this is how it works. So 766 patients were eligible, 180 were enrolled. If you see the red box, actually the 90 patients that were assigned to go to receive ECMO, actually 22 of those never received ECMO. 5 of them died or couldn't get in, and 16 just improved with getting conventional management. The other thing is, if you see the left box, is that if it's basically what I just described. So death or disability at 6 months. The ECMO group was 37%, and then the non-ECMO group, the conventional management group, was 53%. And then if you look at the right table at the bottom, the treatments and other management, it's interesting actually. A lot of people in the conventional group got high frequency oscillation jet ventilation, which now we know isn't good. And then a lot of them got nitric oxide, got proned, got steroids. Both the groups actually more in the ECMO, and then Mars as well, which is basically a dialysis for the liver. So more of the people. So actually more aggressive treatment strategies on the ECMO group other than just the ECMO. So that's one of the critiques of this study, and it did show the mortality benefit. But how true is it? We don't know. So that's the only one randomized control trial that actually supports the use of referral to an ECMO center. If you really want to be a purist and say, I think the only thing that it really did emphasize was that if you refer patients to an ECMO center, they do better regardless of if they get ECMO or not. So that's one thing. The other critiques of this study is that the other hospitals actually didn't have a strict protocol they were following. They were asked to do this as best standard practice, but nobody followed if they were using low, like 6 cc's per kg, or they were keeping an eye on the driving pressures or keeping an eye on the plateau pressures, or however they manage these patients. It was according to best standard practice. Hoping that was the best standard practice. So this is the other, again, now I'm just going to go into the case series part, which Khalid's going to rip me apart because I don't have randomized controlled studies to support ECMO. So this is out of New Zealand and Australia. This was published in 2009 in JAMA. Again, the H1N1 flu data that they actually had 68 patients that had suspected or confirmed H1N1 that were put on ECMO. Their median age was 34, so pretty young population. Their PF ratio mean was 56, so pretty sick patient, and their lung injury score or Murray score was 3.8. 48 of the 68 patients in this case series actually survived to ICU discharge, so that's basically 79%. And what they said in the summary was that if you see patients with severe ARDS, literature has shown that it's 52% that people survive, but this actually showed that there was higher survival rate compared to what we know about severe ARDS. Do you guys have any questions yet or no? Okay, we'll wait till the end. So again, more case series. The top one is from Canada, 168 patients, again confirmed in the 2009 H1N1. I'm sorry, I forgot to mention the CESAR trial actually had 30% confirmed, I think, flu patients. I think most of them had it's like they said pneumonia, but they didn't classify. So they did have some flu patients. So this is from Canada, 168 patients, again, confirmed H1N1 flu, found to be hypoxemic, unresponsive to our conventional mechanical ventilation, were treated at 4 ICUs that had the capability of doing ECMO. At the end, they actually found a 66% survival. Again, this is a case series, so this just tells you how well they survived. This study, the second one, is from JAMA 2011. This is a study where they had 80 ECMO referred patients. Again, not all got ECMO. 69, so 86% of the patients that were referred got ECMO. From this, what they said was so they actually tried to compare this. So what they did was they had a pool of 1,756 patients, and they actually found 59 patients, and they could match to the ECMO, the people who got ECMO. So they did. So they matched those patients with propensity score matching, and when they matched those patients with the ECMO patients, the patients who were getting conventional management, they found that the hospital mortality of the matched patients was 52%, and the hospital mortality of the ECMO group was 23%. So they concluded that for H1N1 related ARDS, referral and transfer to ECMO center was associated with lower hospital mortality compared with matched non-ECMO referred patients. So it wasn't randomized control again. This was the propensity match. Yes.
Just as I'm going to be the moderator here. It's 12:30.
Oh, sorry. Yeah.
So you need
we started a little late. Okay.
Give your colleague a chance to speak as well.
I'll just power through everything. Okay. Okay. This last one was from Duke. This is a small study. Again, showed improvement. This study, this is from France, and again, this was a cohort analysis. They actually did kind of the same as the other study did. They had a total of 123 patients. And what they did was the patients who were on ECMO, they found that 56 of those patients who were on ECMO, they could find a matched analysis for half of those patients, but half of them they couldn't match. But when they matched the patients on ECMO to the patients non-ECMO, they didn't find any mortality benefit. And then the ones that they couldn't match were younger and sicker patients, but the ones they couldn't match and were younger and sicker did better than the ones that were matched on ECMO and non-ECMO matched patients. So it's a little confusing, but I'll just go through this quickly. This is how they actually classify the survivors and non-survivors on ECMO. So patients who didn't do well, the survivors actually had lower plateau pressures and lower plateau pressure differences before and after ECMO, lower requirements of PEEP, and lower lactate levels. So what they said was, so this is the non-matched group that they had. Their mean age was less. Again, they were actually their BMI was higher, but they were sicker. Their lactate was higher, but they did better. But they weren't matched, so they couldn't really definitively say anything about it. So this is at the end. This is a systemic review of all the studies. So I mentioned this one. This is the first one, which was VA ECMO. So we'll ignore that. This was ECOR. We'll ignore that too. This is the CESAR trial and the two trials that I mentioned that they matched, did propensity matching. What these guys, when they put all these patients together, all these three studies, they actually ignored these two. It's not just me saying that. They ignored these two too. When they pooled these studies and they compared the people on ECMO, just strictly people on ECMO versus people not on ECMO, they didn't find a mortality difference. But when they pooled the studies of patients, total number of patients who were referred for ECMO, and versus the patients not on ECMO, actually the patients did better who were referred for ECMO. But at the end, they just said, we don't have enough data and we don't have enough randomized control trials to actually definitively conclude anything. These are all the case reports that were actually published since 1977 up till 2012. So this is, interestingly, this is the same article. So what they did was they actually they used SOFA scores and other objective data to identify or predict their mortality, and then they just reported the observed mortality in these case series. So if you see on like people who were on ECMO, their predicted mortality was pretty high, even just with the objective scoring, and their expected mortality was lower. So after they put all this and these together, and then they said, well, we don't have enough evidence to go for and against it. We need more trials. This is again some trials saying that referral to ECMO centers does better. Early referral has better outcomes. So again, now we know we actually have known how high the mortality for ARDS is, and how sick people are. We've got more technical developments in ECMO since 1979, and now there's an ELSO, extracorporeal life support organization, and a registry that helps us kind of keep track of those patients. Are you gonna? Okay, I was like, you're gonna shove me. Okay, yeah. Sorry about that. So challenges again: patient selection cost, the complexity, lack of any protocols that we have for any timely initiation of ECMO. I was just gonna briefly touch on the cost, but that's okay. I think Khalid can do it. And then last thing I wanted to point out: we don't have any other appealing evidence if our conventional management fails. So we know that high frequency oscillator doesn't work. We know that nitric oxide actually causes a brief improvement in oxygenation, but then can lead to tachyphylaxis, and then afterwards can cause AKI as well. So we don't have any good alternative. And this is 25 years of failed drug trials for ARDS. So not having a good alternative and having some evidence for ECMO, and there's more to come. So this is a trial going on right now. They're actually enrolling patients. This is in France, the EOLIA trial. You can look this up. What they're doing is they're actually, again, trying to figure out early enrollment for ECMO, like in 1 to 3 hours, if they're not doing better, would do better. And these are all the other studies, all the questions we have now managing patients ECMO, like how to manage a ventilator, what are the best antibiotic, sedative, analgesic approach to ECMO, and how do we ventilate, again, 2 of these trials. So I think we're going to have more evidence. Right now we can't really say for sure, but we have some evidence, and then we don't have any other alternative good one. So again, the key message is timely data supports that at least referral to an ECMO center does the severe ARDS people do better. The technique in principle is simple, but we still are understanding this. And patient selection is pretty pivotal. And then lastly, we don't have any good alternatives. I would like to thank Dr. Huda and Janet, who helped me put this presentation together. Don't shove me.
Is it recording? Okay. All right, good afternoon, everybody. I'll be talking about cones of ECMO for severe ARDS. Of course, first I would like to thank Dr. Razvi for actually helping me out with this and reminding me that I have presentation this week. So I went online and wanted to have mostly an idea about ECMO and who to ask. So who's more important than the most interesting man in the world? And this is what he had to say to me, just because he can. Well, that says a lot by itself. If you just listened, if you attended the M&M this morning, and also you listened to Dr. Razvi's presentation, you already know the cons of the ECMO, or I shouldn't say the cons of ECMO, but the cons of all the studies that have been carried or been done on ECMO. But let's take a look a little bit in history. The idea of having an extracorporeal oxygen membrane or bubble been basically studied in the 60s, and the first successful ECMO I think was done in 72. I'm not sure, 71 or 72, but the first randomized controlled trial was done by NIH in 74, and it took 5 years, and the result was released in 79. Basically, they involved 90 patients, 42 were in ECMO, VA actually, and the strategy for those patients showed that they had high infiltrate. They were comparing patients who received mechanical ventilation with a high pressure and low position or low PEEP. And it showed a mortality of 40% with conventional treatment, and 40% on ECMO and 33% for the conventional treatment. Then also Dr. Razvi showed another study carried by U of M in 94, also was a randomized controlled trial, And at that time, apparently, there was the popular use of the inverse ratio of inspiratory and expiratory time, and compared to the ECMO. But at that ECMO, they had a different technique. They were doing low flow ECMO. They had 20 to 30% flow, less flow than the cardiac output, and it also showed higher mortality in the ECMO patients. So both randomized control were a failure. Then we had 2009, when the endemic of H1N1, and we have multiple studies that are coming up, and also one of them was a CESAR study. Most people, I'm pretty sure the medical community was fascinated by these studies, but I was more concerned about Michael Jackson's death in 2009 than this study, to be honest. In this study, in CESAR study, so let me ask, who exactly was masked in this study? And the actual mask were the analysis people who looked at the patient post-discharge after 6 months, not the physicians or not the centers who received the patients. And the 90 patients who went to ECMO centers, only 75% received ECMO. As Dr. Razvi said, 5 patients died. 3 died before being transferred, and 2 died en route, actually. And as we said, the rest did not receive ECMO, and I'm going to tell you the exact number who survived from those percentage. This is the same table that Dr. Razvi showed, but I would like to just focus on the, is this working? The steroid use. So we say that it's 84% more patient in the ECMO compared to 64%. That was statistically significant, and well, ECMO did show that it prolonged the, and we also said that they have more prolongation use of ECMO, and time under strategy was more days under ECMO than with conventional. With ARDS, everybody knows that a late stage you present with, or you can develop fibrotic stage, and the use of steroids might be initiated, and that's a different animal by itself. I'm not going to go into details about it, but as Dr. Razvi said, more intense treatment was done in the ECMO patient compared to the conventional treatments. And sorry about that. Also, the other things that they did look into, or what they did in the ECMO, they did not look into the conventional patient or conventional group because they don't have any control over it. That they did actually the low tidal volume, low PEEP, the diuretics to dry weight, although I have separate opinion about that. RBCs, where they had to target 40%, prone positioning as well, and they also did show they did have more albumin nutrition for the ECMO, and that's also different topics, but albumin nutrition for ECMO group were more than conventional treatment or conventional group. The second table that he did show was about the patients who actually died in 6 months. So if you look at, the only number I care about is the relative risks, actually. So yes, it did show that there is that less people died on ECMO, but if you look at the relative risk, it's not that significant, with a p-value of 0.007. That's not significant at all. And also, if you look at the data of the CESAR trial, the mortality data was analyzed on the basis of treatment, which is fair, but the difference between the groups was even less, of actually 0.9. Then we have this other study, which Dr. Razvi also talked about, which happened in Australia and New Zealand. Just a little bit about the H1 or the swan flu back in 2000. Actually, 37,000 plus were confirmed to have H1. Almost 191 people died of it, confirmed. But they believe that more people had H1, but they did not test it. So only severe patients were tested for H1N1. What's wrong with this study? Well, of course, it's an observational based on case series. It wasn't even randomized. It has a small number, only 68 patients. They were unable to report on the possible outcome of patients if ECMO had not been used. So they didn't have any comparable group, unlike CESAR, which is also not very well made. And also, one of the points they also made in their article or in the study that they have more use of ECMO, so they possible the increased survival was noticed with the increased use of ECMO. Maybe they become more familiar with it. Another study with the referral to ECMO centers and mortality also for the H1N1 group. This one was published in 2011 by Dr. Noah, and what it did show as well, it was what kind of study? It was actually a matching study. So there was a confounding factors that cannot be explained or cannot explain the difference in outcome. So that's the thing about matching studies, that is one of the weak points about it as well. And also the management of non-ECMO patients was not part of the study. So we don't know what happened to patients who received the conventional treatments. And so the thing also about it that the non-ECMO patients, when we can look at it, they were referred maybe just too sick to receive ECMO, or too sick to be referred actually. So that's one downside of the study. And then this article go back to 2006. But the reason I'm bringing it up actually is because it looked at outcomes between centers, and it looked at 20,000 patient plus who were registered in who received mechanical ventilation at 37 centers registered in the acute physiology and chronic health evaluation clinic information system, and looked between 2002 and 2003. I'm not going to go into all the details about it, but it did show that mechanical ventilation of patients in hospitals with high volume had better outcome than patient receiving mechanical ventilation in low volume. And this one point that Dr. Razvi also did show, that an expert center might play a role. So after talking about the main study that he just talked about, is the evidence sufficient enough for us to say that ECMO is good? Well, this is an editorial article actually, and he did criticize the Dr. Noah's research, which is referred to the ECMO centers, and also the CESAR research, and to the same points that we did talk about, I did bring up. But I don't know if you can read this, and this is from the article. I'm just going to read it loud. While underlying risk factors may be different, severe respiratory failure from H1N1 infection presents a clinical challenge similar to that involved ARDS from other causes. Despite several decades of investigation into potential treatment strategies, use of low tidal volume remains the only proven therapy to decrease mortality in ARDS, which is the same thing that we do even when we do the ECMO. This is just an honorable mention of the complication of ECMO. I'm not going to go into details about it, just to refresh our memory about bleeding. If you guys don't know the percentage of bleeding of ECMO, it goes up to 40%, which is significantly high. Thromboembolism as well, despite the high heparin and the blood flow, we can actually see the clots in the tubes, so that's why they have to be checked daily. Cannulation related, surgery related, it goes from perforation and goes from ischemia as well, or hematoma. Also HET, with all this heparin induction or exposure to heparin. And the VA ECMO specific complication, although we don't deal with it, I'm just going to say it was from stroke also, and pulmonary hemorrhage from the retrograde, and cardiac thromboembolism from this retrograde flow that happens with the VA ECMO. Too short. We don't have a lot of evidence. That's why it's too short. That's why I thank him for taking that much long time. But the way we should look at it, actually, does the underlying cause of ARDS play a role in ECMO benefit? All the proven that we've been talking about that came after the H1N1 flu. What about if we have bacterial pneumonia that causing ARDS? What about pancreatitis? What about any other cause of ARDS? So, and look at the response of patients with conventional treatment in ECMO centers that were initially referred for an ECMO. So what I'm saying is, the patient who were referred did not receive ECMO, yet still benefit. And I'm referring to the CESAR trial. And from the patients who actually did not receive ECMO, from this subgroup, mortality was only 18%. And my last point, with severe ARDS, maybe we just should consider the need for an expert center, as I said, with higher volume, with an expert treating team from physician, RT, or RN as well. So if somebody asks me, does ECMO improve outcome in patient with severe ARDS, life-threatening respiratory failure? I don't know, or I should say no. We had actually a talk, I forgot her name, by a pulmonary critical care attending from U of M at our department of Nephrology, talking about ECMO, and I think the best description that she told us is look at it as a bridge. We don't know where it takes us. It depends when you walk that bridge. Is it too early, too late? Still a lot of studies need to be done, if needed to be done actually. Thank you.